Today I am going to do the second lecture of the hematology series, and in this lecture I am going to talk about ESR, a very important section during the first few minutes, which is going to be followed by another interesting disease, that is multiple myeloma. Now I am going to start with the case history. Now we have a 55-year-old female presented with painful swelling of right arm of 2 weeks duration. The main complaint is painful swelling of right arm. In addition, she complains of severe body aches, bone pain, malaise, tiredness, lethargy, and significant weight loss. But she does not give a history of fever, and although she has a painful swelling, there is no history of trauma. And in addition, there is a past history of renal stones, recurrent respiratory tract infections as well. On examination, I will just go through the positive signs only. She was pale, and then there was a tender swelling of right arm with restricted movements due to pain. She was not able to move the right arm at all due to the pain. And in addition, there was a tender point over the thoracic vertebra. So, as an initial investigation, the ESR was done and it was found to be significantly elevated up to 120 millimeters per hour. Now, before I go further, I will explain what is ESR. Now, ESR is the amount of red cell sedimentation in a given period of time. It is a very inexpensive investigation, so therefore it is widely used as a screening test, but it's very non-specific. It can be elevated in many diseases, and it does not signify the severity of illness in most instances. And it measures how much red cells will settle in a given time. The unit is millimeters after 1 hour in hours, and it's a non-indirect and non-specific measure of inflammation or infection. If you do the ESR, now you allow the blood to stand, and what are you going to measure? You are not going to measure the column of the red cell, but you are measuring the column of the plasma after a specific time, that is after 1 hour. So how much the plasma is remaining after 1 hour because of red cell sedimentation is ESR. So ESR is, that is this bit, right? So ESR is directly proportionate to the weight of the cell aggregate. So if the weight of the cell aggregate is more, it will aggregate more and the ESR will be high, and it is inversely proportional to the surface area. And if the surface area of the red cell is high, the plasma column will be low, right? So it is directly proportionate to the weight of the red cells and inversely proportionate to the surface area. Now, now what is the mechanism of ESR? So if you know the mechanism, you know you don't have to by heart the conditions where you get high ESR. The normal red cells are negatively charged. The surface of the red cell is negatively charged, and because of that, within the circulation, the red cells repel each other. They do not bind together and form clumps because all the red cells are negatively charged. Whereas the surface of the proteins are positively charged, not all, some of the proteins. Right? So some of the plasma proteins, especially fibrinogen, right, when they have increased quantity, they are positively charged, they can bind with the negatively charged red cell membrane and neutralize the red cell surface and making the red cell adherence and what is called rouleau formation. So negatively charged red cells will bind the positively charged uh, plasma protein and cause adherence and rouleau formation. Now, what are the requirements to do a ESR? So it's a very simple technique. What you need is just a EDTA blood, and the apparatus required are but the thin tube called Winthrop tube and Winthrop stand, and there's a needle, a special needle where you insert blood, that is called ESR needle, and timer, right? And it's important the procedure must be performed within 2 hours of blood collection, right? So if the blood is in the room temperature, you should do the ESR within 2 hours of blood collection. So this is the Winthrop tube and this is the Winthrop stand, and then you insert the blood and keep for 1 hour and then get the reading, this reading, and it should be extremely vertical. Now there are many factors affecting the ESR, because when you become house officers, you should know these things for proper collection of blood for ESR so that it will give an accurate results. Right, now there are physiological factors as well as laboratory factors. Now what are the physiological factors? They are plasma factors, red cell factors. I will explain during next slides. Rouleau formation, age, sex and pregnancy. And the laboratory factors are temperature, time, anticoagulant, tube factors like tilting of tube, vibration and sunlight. Okay, what are the plasma factors? Now, you already know that substances like fibrinogen, globulin, cholesterol, they are positively charged and they can bind with negatively charged RBCs and promote clumping and increase ESR. But this does not happen with plasma albumin, and actually the plasma albumin can retard the sedimentation of RBC. Now, if we take the red cell factors, now number, if the red cell number is increased, the red cell mass is high, so the sedimentation is less, so that can cause decrease ESR, as opposed to the reduced red cell mass in anemia, less red cells, less aggregation, increase ESR. Now if you take the size, it's very interesting, because now you know macrocytes has more surface area than the microcytes. So theoretically speaking, the macrocytes should have, if there is a lot of macrocytes, the ESR should be less, because there is less sedimentation because of large surface area. But what happened actually is, now that these macrocytes are heavier than the microcytes, right? So because of that, the microcytes sediment slower than the macrocytes. So in in microcytes, the ESR is less, right? So if you take the shape also can affect the ESR. Now, if you take the sickle cells, so they have abnormal shape, so the clumping will be reduced, and because of that, the ESR will be less. Now, what about rouleau formation? Now, in rouleau formation, the red cells are nicely stuck one over the other. So it can settle down in a uh, uh, in a settle down well and pack and in a very small area, and they can be packed together so that there is like a clot. So if there is Roulet formation, the red cells are tightly packed. Because of that, the ESR is always high. So this is an important cause of high ESR. So if you take the other physiological factors, in infants the ESR is very low, and in elderly it is generally high. The value is high. So if there is like a subtle elevation of ESR, in an elderly person we take it as normal. In females, the ESR is higher than the males due to low pack cell volume. And during pregnancy also, the ESR can increase and it returns to normal after about 1 month after the delivery. And it's very important, in hemolyzed and clotted sample, there is low ESR. It's a false value because the positively charged fibrinogen is trapped inside the clot. So you have to make sure that the sample is not hemolyzed or clotted. So the general assumption is the equation is then ESR is age in years divided by 2, and in case of a female you have to add 5. So if you take a 80-year-old male, the ESR up to 40, you can't say it's abnormal, and in female 80 years old, even up to 45, you can take it as normal. So this is the general rule. Now if you take the laboratory factors, the time. Now the test should be done, as I said before, the test should be done within 2 hours of collection, right? So you cannot take the blood at 8 o'clock and send the sample at 12 o'clock. And it should be always in an EDTA bottle, otherwise the sample will be clotted. And if the sample takes more than 2 hours to go to the laboratory, it should be kept at 4 degrees centigrade, and still it should be performed within 6 hours, right? So in a collapsed patient, if you need to take the blood in an odd time, then you have to keep it in a refrigerator at 4 degrees centigrade and should do it within 6 hours. Otherwise, at room temperature, need to do in 2 hours, right? So generally the test is done at 20 to 25 degrees centigrade, and if the temperature is high, you can get falsely elevated values because there is reduction of plasma viscosity. And it's important that if we refrigerate the blood, we have to bring the blood to room temperature before you do this temperature before you do the test. And it's in it has been found that there's a with every 3 degrees of temperature, the ESR will increase by 1 millimeter. Sorry for the mistake here. Right, so there are certain drugs that can affect the ESR, like plasma expanders like dextran, right? So can increase the ESR. Likewise, methyl-dopa, contraceptives, etc. And aspirin, steroids, and quinines can decrease the ESR. Now, why the ESR is high in disease? Now, you know, acute phase proteins are elevated in infections and inflammation. Now, CRP is an acute phase protein. Since it is elevated, the CRP is high in infections and some inflammation. And because these proteins are positively charged, the ESR is also high uh, in infections and inflammation. But when there is high immunoglobulin, there are certain conditions where the immunoglobulins are disproportionately high. In those situations, the ESR is disproportionately elevated to C-reactive protein. Now, what are the conditions where in addition to the acute phase protein, the immunoglobulins are, there is immunological reaction as well. For example, in infective endocarditis, conditions like rheumatic fever, rheumatoid arthritis, SLE and other connective diseases, and conditions like inflammatory bowel disease, multiple myelomas and malignancies. And these conditions, the ESR will be significantly elevated. In certain instances, it may be more than 100 and even in some chronic infections as well. Right. So this is the list of conditions. Now you can work out some of these conditions where you can get elevated ESR and where you can get reduced ESR. Right. If we come back to our case history, 55 years, or I can't remember the age, yeah, 50s, severe bone pain and recurrent respiratory infections, high ESR. The next investigation, the basic investigation is we do a full blood count. Now these are the results of full blood count report. HB is 8, that is low. WBC is low with normal differential. Platelet is 86. Now you know from the knowledge of your previous lecture, now this type of report occur when there is bone marrow pathology, some bone marrow problem. So the blood, it is associated with blood picture. Now this is the blood picture of that patient, and what does it shows? It shows marked rouleau formation. So there is so far very high ESR, pancytopenia and marked rouleau formation. And then the next investigation, the patient came with severe bone pain and the X-ray of shoulder and the right humerus. And this is the appearance of the patient's X-ray. It shows there is some osteopenia as well as some lytic areas, as well as there is a pathological fracture. So we know why we said pathological fracture. There is no obvious trauma. So we know that this is the cause of this patient's severe bone pain. So these are the features this patient has got so far. Pancytopenia, high ESR, rouleau formation, lytic lesions and pathological fractures. So the differential diagnosis is whether this is some bone marrow infiltration and whether this is multiple myeloma. The bone marrow infiltration can cause any of these things, but it's unlikely to cause rouleau formation. But the multiple myeloma can cause all these features, which I will explain how in my subsequent slides. So what is multiple myeloma? Multiple myeloma is a plasma cell neoplasm. So it's the cancer of the plasma cells which cause abnormal proliferation of one type of plasma cells causing one type of immunoglobulins in the bone marrow. Right? So it's a very rare disease and it's a disease of elderly. Although it's rare, it is very interesting disease because the complications of the disease are common. So you have to have it comes in the differential diagnosis of these complications. For example, they can cause renal failure, unexplained renal failure with high ESR, or they can come with hypercalcemia. So you have to keep this disease in mind all the time. On the other hand, it is academically very interesting because all the physical science you can explain. You can explain the pathophysiological basis of all the physical science. Now, if I recap your memory about the immunoglobulin or antibody formation, it starts from B lymphocytes. B lymphocytes produce plasma cells, and the plasma cells will produce immunoglobulin. Now, here the problem is here. So, there is abnormal proliferation of plasma cells causing increased production of immunoglobulin by that type of plasma cells. So, but this is called monoclonal gammopathy. That is only one type of immunoglobulin. So this can cause elevation of gamma globulin. So that is called, because of that, it's called monoclonal gammopathy. So in myeloma, most of the time they produce IgG in about 50% of cases, and in 20% of cases IgA, 20% of cases only the light chains, and the other type of immunoglobulin production is rare. Now these increased immunoglobulins are called paraproteins. Okay. Now we know that there is abnormal proliferation of plasma cells, and it can cause 4 pathophysiological abnormalities which are responsible for the production of signs and symptoms in myeloma. So that's why everything can be explained, all the signs and symptoms can be explained in multiple myeloma. Now first, you know, abnormal proliferation of plasma cells, there is increased production of immunoglobulins or paraproteins. So that is one thing. The second thing is, now this proliferation occurs generally in the bone marrow. So there is bone marrow infiltration and suppression causing various signs and symptoms. Then this plasma cells, abnormal plasma cells producing a substance called osteoclast activating factor. So that is responsible for some other group of physical signs. So the fourth one is, sometimes this proliferation occurs like a solitary area. It's not generalized, but a focal area like a solid malignancy. So it's a localized proliferation can occur, so producing a solitary mass. So all the pathological signs and symptoms occur due to either one of these 4 processes. Right. Now, if we take bone marrow infiltration, you know, can cause anemia, bleeding due to thrombocytopenia, and cause leukopenia, causing recurrent infection. Now, this patient has had recurrent infections for last few weeks. Now, I said these plasma cells producing a substance called osteoclast activating factor. The action of this substance is it increases the osteoclastic activity and reduces the osteoblastic activity. You know, the osteoclast can cause the reduction of bone mass, and osteoblasts are responsible for the formation of bone. So these plasma cells produce osteoclast activating factor, which increases the osteoclastic activity and reduction of osteoblastic activity. Now this leads to pathological fractures. Now the bone is eaten away by the plasma cell, this substance produced by the plasma cells, right? So the bone become weak and they become fractured either with no trauma or minimal trauma, right? And then because of this increased osteoclast activity, the classical appearance occur in myeloma, that is lytic lesions in the bone without surrounding sclerosis. So they can like punched out type of lytic lesions. Why there is no sclerosis? Because there is no osteoblastic activity. There is no osteoblastic activity. So they are just lytic lesions without surrounding sclerosis. So this is very typical of myeloma. Commonly occur in the axial skeleton like skull, spine, pelvis, shoulder girdle, but can occur anywhere. So yeah, the pathological fractures, and then because of this bone eating away can cause severe bone pain, right? So they present with back pain, they can present with localized pain even without pathological fractures. Lytic lesions can cause pain. And then the pathological fracture sometimes in the vertebral column can cause spinal cord compression, a complication of myeloma, and then generalized osteopenia. So the increased osteoclastic activity so can cause hypercalcemia. So the calcium is reduced to the circulation and it can cause hypercalcemia. So this is a lytic lesion, it's like scoped out from a spoon without any sclerosis. And there is another one. And then you can see a pathological fracture in our patient with large lytic lesion. The skull X-ray of myeloma has very typical classic appearances. This is the skull X-ray appearance. It can cause multiple small, well circumscribed, sponged out round lytic lesions of different sizes. So this is the classical appearance. It's resemble raindrops hitting the surface and splashing. If you imagine this, that is the appearance they describe and call raindrop lesions, or some people call it pepper pot skull. It's like a pepper pot. And then in addition, you can get endosteal erosion, that is scalloping of the inner side of the, no, you can't see here, inner side of the bone, skull bone, there is scalloping. So these are the classical skull X-ray appearance of a patient with multiple myeloma, and you know why it occurs. Now this is multiple vertebral collapse due to pathological fractures in myeloma. Now you can see, now you can see multiple vertebral fractures. Now the third, the pathophysiological cause is I said it can occur as a solitary mass. So the proliferation can occur like a solitary mass. It's not generalized. So when it occurs like that, it's called plasmacytoma. These plasmacytomas can occur either in bones or outside the bone. And if it's outside the bone, it can occur anywhere as a painful lump. Now here you can see it's the bone, and here you can see here in the spine, MRI of spine showing the plasmacytoma, and then this is in the skull bone and infiltrating the compressing the brain matter, causing, this patient can present like a CVA or focal neurological deficit, and this is just a lymph node, right? So in the skin. So remember, it can occur anywhere in the body. So we have discussed the abnormalities due to bone marrow suppression or infiltration, osteoclast activating factor, solitary mass, and the fourth one is increased production of para. Right. So although there is increased production of immunoglobulin, now these immunoglobulins are not normal. There is only one type of immunoglobulins are increased, and sometimes they are not full immunoglobulins, only the light chains are increased, right? So although there is increased immunoglobulin, there is immunoparesis. The patient is immunodeficient and resulting in recurrent infections, right? So that's important to remember. And then I said these light chains, when there are increased light chain production, they will filter in the glomeruli and then they can reabsorb and deposit in the tubular cells, and these can cause tubulopathy and renal disease. And the light chains are responsible for the increased viscosity, and that itself can cause many symptoms which I will discuss later. And you know, AL amyloidosis. Now, amyloidosis is also a type of immunoglobulin light chain. So this AL type can be increased, and this can deposit in various organs uh, like tongue, causing macroglossia. They can deposit in the heart, causing cardiomyopathies, GIT, liver, and neurological involvement like neuropathies and carpal tunnels. So there are a separate group of disease, symptoms and signs purely because of increased production of paraproteins. Investigation is we need to confirm the diagnosis of multiple myeloma. So we have to do the next test is bone marrow biopsy. We normally do not the aspiration, the trephine biopsy. So the plasma cells has this classic bluish purplish kind of appearance due to their large nuclei. Uh, they are kind of eccentric large nuclei. So if the percentage of plasma cell in the bone marrow is more than 10%, it is diagnostic of multiple myeloma. And in our patient, this is the bone marrow report. The bone marrow is totally infiltrated by about 90% of plasma cells. So this patient's the diagnosis is multiple myeloma. And then if you want, we can test for paraproteinemia by doing serum protein electrophoresis. Now this is the normal serum protein electrophoresis in a normal person, where you can get this spike is due to albumin, then beta 1, beta 2, and this is gamma globulin. But in myeloma patients, because of this increased immunoglobulin, this gamma globulin spike is high. If you take the picture like this, it is a very thick area because of increased gamma globulin. Now this is called monoclonal gammopathy, and you can do the what is called urine Bence-Jones protein, a very simple test which I will explain in my next slide. And then these immunoglobulins can filter and appear in the urine, so you can do the urine protein electrophoresis, and you can classify the type of immunoglobulins by doing the immunoelectrophoresis. So all these tests can be done to test for the paraproteinemia. So few words about Bence-Jones protein. It is due to urinary excretion of increased amount of kappa and lambda light chains. So it is the Bence-Jones protein is positive because of increased excretion of light chains. Now it is a very simple bedside test, even you and me can do. The test is heat test, where it is based on the fact that this Bence-Jones proteins precipitate when you heat the sample. It precipitate at the temperature of 56 degrees centigrade, and if you keep on uh, uh, heat the sample, it will again dissolve when the temperature is raised to boiling point. So I hope you understand. It precipitates at 56 and then it dissolves when it goes to the boiling point. And same results will occur when during the cooling as well. So in the boiling point, it is dissolved and at 56 degrees, the precipitation can occur. So it's a very simple urine test, can do as a bedside test. But for quantification, you need the 24-hour urinary collection. Right. Now, these investigations are enough to diagnose uh, myeloma. Now, why you need to do the other investigations? Now, you can, I know that, you know that they can cause hypercalcemia due to osteoclast activating factor. So, you have to do the serum calcium to see whether the patient has got uh, increased calcium. Then multiple myeloma can cause renal disease due to various techniques, various methods. So you have to check the serum creatinine and see whether the patient has got renal involvement. And then can cause recurrent infections. CRP is important. And increased cell turnover can cause increased uric acid and the problems due to increased uric acid. And then again increased cell turnover can cause increased LDH. So once you diagnose this by doing this test, you have to do these tests also to prevent further complication. Now, now in this patient the diagnosis is obvious, but there are certain patients the diagnosis is not as obvious as this patient. So in those scenarios, you should have some diagnostic criteria to diagnose multiple myeloma. Now, to diagnose multiple myeloma, you need a clonal bone marrow plasma cell proliferation more than 10%. And then monoclonal in protein either in the serum or in the urine, and then organ involvement. So these things should be there to diagnose. Before I go further, uh, I would like to tell you now the myeloma, there is a disease spectrum. Now it starts from monoclonal gammopathy of undetermined significance, or commonly we call it MGUS, and it takes about 10 to 15 years to develop active myeloma, and in the process there is asymptomatic myeloma or smoldering myeloma. So there are diagnostic criteria for each of these three uh, disease conditions. So first I will discuss the criteria to diagnose active or symptomatic myeloma. Now for that you need one of these two features. The first one is there is bone marrow plasma cells should be more than 10%, or biopsy proven bony or extramedullary plasmacytoma. Right? So when the bone marrow should be positive, or the uh, the the bony there should be evidence of plasmacytoma in a biopsy. So with that, there should be one or more features called myeloma defining events, right? So either of these things plus one or more what are called myeloma defining events. What are these myeloma defining events? Now, commonly we call it CRAB criteria. So why? It is C for increased calcium, renal insufficiency, anemia or bone lesion. So with the bone marrow involvement, if the patient has one of these things, it is diagnostic, we can label the patient as having active multiple myeloma. So these are the other myeloma defining event. I put it as for the sake of completeness. So CRAB criteria are important, right? So either one or more of myeloma defining events should be there in addition to the bone marrow involvement or solitary plasmacytoma. Now, what are the criteria to diagnose smoldering myeloma or asymptomatic myeloma? Here also, uh, patient can have either of these things but without myeloma defining event. So if the patient has only bone marrow clonal proliferation of plasma cells more than 10%, or there is plasmacytomas but without any other features. There is no organ involvement, no hypercalcemia, no renal disease, no anemia or bone lesions. Then it is called inactive multiple myeloma, but definitely they will progress to myeloma. So you need a very careful follow-up. When do you diagnose MGUS or monoclonal gammopathy of undetermined significance? Presence of monoclonal immunoglobulin or paraprotein without evidence of myeloma. So there's just increase in monoclonal immunoglobulin, but there is no evidence of myeloma. Now here there is bone marrow plasma cells are increased, but it is less than 10%, right? And there is paraproteins will be normal, will be elevated, but not much. There is no immunophoresis, so there's only slight elevation of bone marrow plasma cells with no organ involvement, no hypercalcemia, no anemia, no bone lesions, not much elevation of paraproteinemia, then you call it MGUS. It can transform into myeloma some point. Sometimes it takes 10 to 15 years. So you don't need any treatment, but it's very important to follow up these patients, right? Sometimes the patient does not understand the importance of follow-up. So that is the catch when the earliest sign of myeloma is there and treat. Right. Now, I don't have to tell the complications. You can work out the complications since you know the pathophysiology. Just they can cause fractures, they can cause neurological problems either because of plasmacytoma or pathological fractures, and then they can cause hyperviscosity symptoms, problems due to amyloidosis, hypercalcemia, renal failure, infections, bleeding or anemia. So it's important. Now some of these are not very uncommon. So it's a uncommon cause of common problem. So it is important to know about multiple myeloma. Now I said about hyperviscosity syndrome. It is caused by increased paraproteins in the circulation. That classically they can cause visual symptoms because these retinal arteries can block because of this increased paraproteins. They can get bleeding and they can get neurological symptoms. The treatment is you have to hydrate or remove these proteins by the process called plasmapheresis. Now, these are the poor prognostic features of multiple myeloma. Now, if these features are there on admission, the survival rate is reduced. Now, treatment. Now, this is, you don't need to know the treatment of multiple myeloma, but it's important to know the fundamentals of treatment because when you're a house officer, you can come with complications of treatment. So you should know what are the drugs they get and have a basic idea about the side effects and the modes of treatment. So generally, Melphalan is a very old drug. Even when we were medical students, this is the drug of choice for the treatment of myeloma. In addition, prednisolone, cyclophosphamide, and thalidomide. Thalidomide is a, I think you know about this drug in pharmacology. It is a drug that can cause a lot of limb abnormalities, and it has been given in 60s for um, as an for morning sickness for pregnant female, and it's very teratogenic drug. So it has re-emerged as a treatment for multiple myeloma. And then you have bortezomib as well, especially in renal disease. So these are the drugs we use. Just read about at least one or two side effects of these drugs, right? And remember, conventional cytotoxic drugs which are using for other malignancies are not generally effective in multiple myeloma. So two methods of treatment, that is intensive therapy and non-intensive therapy. In intensive therapy, here what we do is 2 or 3 combination of drug followed by autologous stem cell transplantation. So it's the another option of treatment. And in non-intensive treatment, where you just give the drugs which I mentioned in various combinations. In addition, when you come across a patient with myeloma with these complications, it is important to give supportive therapy. For example, anemia can be treated with blood transfusion, or if it's due to renal disease, can give erythropoietin. Hypercalcemia, IV fluid bisphosphonates like IV pamidronate, zoledronic acids. And then, like I said before, if the patient presents with hypoviscosity, you have to hydrate the patient. And if it doesn't work, plasmapheresis. Recurrent infections should be treated with parenteral antibiotics and sometimes prophylactic vaccinations. Bone pain, sometimes local radiotherapy is given for bone pain, high dose steroids, and bisphosphonate. Generally, we do not request to give NSAID for bone pain in multiple myeloma. And for the prevention of pathological fractures or treatment of pathological fractures, we use various orthopedic procedures. Now, as a continuation from the first lecture, what are the causes of anemia in myeloma? Now you know there is bone marrow infiltration, there is erythropoietin deficiency because of renal failure. Patient will be very ill, loss of weight, loss of appetite, and the bone pain that will cause a lot of nutritional problems, and thrombocytopenia can cause bleeding and anemia of chronic disease. Renal disease in myeloma, there are several mechanisms. Now, like I said before, excess light chains, they can accumulate and precipitate in the distal tubule, cause what is called karst nephropathy. And also they are directly toxic for the proximal tubules, so causing tubulopathy, tubulointestinal disease. And then hypercalcemia and dehydration can cause renal disease. Hyperuricemia can cause renal disease. Amyloidosis can cause renal disease. If you use a lot of NSAIDs, bisphosphonates, it can cause acute tubular nephrosis, as well as hyperviscosity can cause renal failure, and they can cause recurrent infections like urinary infections causing pyelonephritis. Just for the sake of completeness, I will just mention about the myeloma related diseases. Now you might come across these words in time to come. So the one is called Waldenström's macroglobulinemia. The other one is plasmacytoma. It's a myeloma related disease. And then the primary amyloidosis, that is if the patient has excess AL light chains, then can cause amyloidosis, and the what is called Poem syndrome. So just few words about Waldenstrom's macroglobulinemia. Now, as opposed to plasma cell proliferation in myeloma, here the proliferation is the B lymphocytes, that is one step before the plasma cells. So it's a neoplastic proliferation of B lymphocytes causing increased plasma cells and causing elevated, here it is the type is mainly IgM. So that is why IgMs are big molecules. So that's why you call it macroglobulins, right? So this neoplastic lymphocytic B lymphocyte proliferation can occur in any organ. So they can cause organomegaly, commonly lymphadenopathy, and splenomegaly, and also increased macroglobulin cause hyperviscosity, and they can present with neurological features. Okay. About Poem syndrome, just know Poems means polyneuropathy, organomegaly, endocrinopathy, monoclonal plasma proliferative disorder, and skin changes. So if we have combination of these things, you call it Poem syndrome. Just good to know. We do not ask in the exams. That's all. So if you have any questions, this is my email, and there were some questions from my last lecture. So any questions, just mail to me. Thank you.